Welcome to the Mayo Clinic Cardiovascular Masterclass. Please take a moment to read over the learning objectives for this presentation.
So, moving then on to atrial fibrillation, the two fundamental questions, as I'm sure you know, but just to reinforce those, each patient you need to make a decision about what are you going to do for their AFib. Are you going to rate control it or rhythm control it? And the other question is, do they need anticoagulation or not? Comparing rhythm versus rate control, it is different really in some of the subsets of patients, but overall, from the AFFIRM trial and those original rate versus rhythm hot cafe trials, there wasn't any major difference whether a rate control strategy was chosen over a rhythm control strategy. So you know that there are potential risks with starting someone on an antiarrhythmic drug. So we're going to have a preference for rate control. But there's some caveats. Those trials, when they were done, catheter ablation wasn't out there, and that's why the Cabana trial, which is the largest randomized catheter ablation trial in the world being run out of here, is looking at specifically that question. Is it different if we subject someone to an ablation strategy versus an antiarrhythmic drug like sotalol? And the average age in those trials was 70. So if a 41-year-old or a 29-year-old comes in with atrial fibrillation, do you rate control that patient? We really don't know the answer to that. Also, though, the anticoagulation strategies at that stage were not ideal in the early 90s when they ran that. So I think this is an algorithm that makes sense, and it's based on the current 2014 guidelines. So if someone doesn't have symptoms, then you would go with rate control. If you're unable to rate control that patient, then reasonable to move on to a rhythm control strategy, and if even that is failing, or in some cases if the patient prefers not a rhythm control medication because of its proarrhythmia, it's reasonable to consider an AV node ablation. But then when do you start off with rhythm control? Make sure that that patient is adequately rate controlled. So some patients have symptoms just because they're tachycardic. So slowing down their rate, and then are they still symptomatic? If that's the case, then fine to start off with a rhythm control strategy. And obviously, as we mentioned, if the rate control strategy is failing. We have seen, though, that it's associated with an improvement in quality of life, but not the other hard major endpoints. So that's the only reason why we would recommend that patient think about a potentially toxic medication strategy, or even an ablation. And we don't have any data yet until that Cabana trial is out on less stroke with regards to catheter ablation. So rate control strategies for atrial fibrillation, and I'm sure you know these, just to run through them. It's really based on your comorbidities. If someone has COPD, you're probably going to avoid beta blockers. CAD, you're going to have a preference for beta blockers. And then only using digoxin if there are recurrent episodes of heart failure. And then finally, amiodarone is a very good rate control agent. So if you've gone through this gamut of medications and you still can't control that patient, it is there in the guidelines as a rate control drug. If others are failing, AV node ablation is also a fallback option. How aggressively do you rate control someone? The specific numbers are not out there, but in general, resting heart rate below 85 beats per minute is accepted. But when this was compared, so in the trials, they've looked at strict versus lenient. Lenient seemed to be with a resting heart rate less than 110 versus a resting heart rate less than 80. There was no change in major outcomes. And so there isn't really a specific target. But in your practice, it's okay for that heart rate to run a little bit on the high side if the patient is doing fine and you're keeping an eye on their ventricular function. Heart failure, the rate versus rhythm question was specifically asked in patients with left ventricular function, dysfunction, and recurrent heart failure. and there was an equivalent outcome whether you used rate control or rhythm control. In practice, though, this comes up quite a lot, and there is quite a bit of animal data and some small series data. Certainly cohorts of patients do better in a rhythm control strategy, and we don't understand why. There is something about the change in the variability of the RR intervals or the consistency, so they can be rate controlled, but some heart failure patients do better with atrioventricular synchrony, with that atrial kick. So in practice, if someone's not doing well and everything else has been looked at, I do perhaps consider a trial of rhythm control. I'm not saying it's definitely better for them, because this has been answered in a large group of patients, several thousand patients, but in practice, I think reasonable to consider, and avoiding dronedarone. So anyone with heart failure, you're going to need to avoid that particular medication. So mentioned already, but digoxin should never be your first-line agent for anyone with atrial fibrillation. It would be as an adjunctive medication if patients are having recurrent heart failure. Be aware that the serum levels will go up if they're using verapamil or amiodarone. So treatment options for rhythm control. From a medication standpoint and from an ablation standpoint, think of just break this into, does the person have a normal heart or not? Because you really are going to go down two different algorithms. We're going to start off just with no structural heart disease. So if that's the case, it would be a class 1 indication to try medication for their atrial fibrillation. And so flecainide, propafenone, sotalol, dronedarone, dofetilide, they're all class 1 in this situation. Remember, dofetilide is for persistent atrial fibrillation. That's its only label. Dronedarone is not to be used in persistent atrial fibrillation. So dronedarone has those two warnings. You cannot use it in persistent AF. You should not be using it in patients with heart failure. If you fail drugs in someone with no structural heart disease, it's a class 1 indication or recommendation to consider an ablation. But if you have a normal heart, it's a class 2A to go straight to ablation if the patient doesn't want to consider a class 1 or a class 3 based on the proarrhythmic potential of these medications. So remember, this is for someone with a normal heart, no structural heart disease. This is symptomatic paroxysmal atrial fibrillation, this class 2A indication here. Persistent atrial fibrillation, we do not have good catheter ablation strategies for. It's usually success rates in the best groups around the world, 60%, maybe a little bit higher. Long term, it's dropping to 50%. So there's no class 2 indication if someone has long-standing persistent atrial fibrillation in a normal heart. This is paroxysmal symptomatic atrial fibrillation. Amio is never your first-line drug. So structural heart disease then, coronary disease or left ventricular dysfunction, sotalol and dofetilide are well studied. Remember, you can use dronedarone here for coronary disease, but not for patients with heart failure. And then if these are failing, reasonable to move on to ablation or amiodarone. Once again, amiodarone is never your first-line agent for these. Maybe it would be because that ends up being because they have, chronic kidney disease and you can't use sotalol or dofetilide, but then you certainly, if you're doing this in practice, need to state that in your documentation. You chose amiodarone because the others were, they were ineligible for the others. So appropriate strategies for new onset and post-op atrial fibrillation. It was released and published earlier this year at the ACC in March of this year. It's a big study, pretty much like the AFFIRM was, looking at what's better, rate control or rhythm control for those patients who've undergone cardiac surgery. So the bulk of these patients had bypass grafting, and then about another 40% had bypass grafting plus a valve surgery or just a valve surgery. It could be aortic valve surgery or or mitral valve surgery. And there was no Mays procedure, left atrial appendage ligation in this study. So you can see here, and this went out several months, rhythm control versus rate control, there was no difference. And so soon coming up, and probably you can inform your surgeons if they weren't aware of this, is that you really should be considering rate control as the first step. Obviously, if you can't rate control the patient or there is an issue with that, then reasonable to move on to rhythm control. But this was only released this year. At the post-surgical atrial fibrillation, there's been quite a lot of work on how do we prevent this, and based on the guidelines now, really only preemptively using amiodarone for that high-risk patient who's had a lot of atrial fibrillation, who are worried about what's going to happen if they go into atrial fibrillation. It is a class 2A to consider amiodarone in that group. Otherwise, treating is going to be after they develop an atrial arrhythmia post-operatively. Anticoagulation is crucial, and it's indicated if they have post-operative atrial fibrillation based on their CHADS-2 VAS score. How long do you continue anticoagulation after cardiac surgery? No one knows that. In practice here, it's going to be on average 3 to 6 months. And in that recent trial, they used beta blockers or calcium channel blockers for rate control. You really should be thinking about this in practice. These are some tremendously impressive results by several groups now, specifically from 2 groups in Australia, but this is not just a small cohort, and these are really fundamentally game-changing results for patients with atrial fibrillation. Diet and exercises changes things hugely. So here you can see weight loss alone, if you're losing only 3% of weight versus 10%, and this is freedom from atrial fibrillation without drugs, it's significant. Add to that exercise training or improving their fitness, and you can change it even more. You can shift that curve much more in favor of avoiding recurrent ablation-free atrial fibrillation, drug-free atrial fibrillation. This is like a powerful antiarrhythmic drug. Really, and you look at your patients who are getting atrial fibrillation, obviously there's some outliers, but these are patients who are overweight, they have sleep apnea, and this changes it. It really does. This is a very powerful antiarrhythmic therapy, an antifibrillatory effect, and you should know that, and this has been 2015, 2014, some of those studies came out. It definitely should be something you should be considering in practice. So I'm going to wrap things up here with the drugs. Amiodarone is never going to be your first-line agent. Remember to avoid your class 1 drugs in structural heart disease. It's going to be dofetilide or sotalol, which are well studied. Know that you can't use dronedarone in persistent AFib or patients with heart failure.
We hope you enjoyed this presentation.